thyroid cancer with metastasis to ascending colon. Case study and literature review. Medullary thyroid carcinoma accounts for nearly 2% of all cases of thyroid cancer. It is known to metastasize to lungs, brain, and bones. However, there are no reported cases of medullary thyroid cancer metastasizing to the colon, which has been reported in the opposite way, colon that metastasizes to thyroid. We present an unusual case of medullary thyroid carcinoma metastasizing to the ascending colon. It was an 80-year-old female who was found to have a 2.9 centimeter nodule in the right lobe of the thyroid gland in 2016 during a routine checkup. 5 months later, a fine needle aspiration biopsy showed a Bethesda 4 medullary thyroid carcinoma with extensive extrathyroidal extension. Thyroid cancer mutation panel with next-generation sequencing was positive for red mutation with a strong expression of calcitonin gene, as we can see in Figure 2, CK19, and chromogramin. The following month, she was admitted to the hospital due to acute low back pain. Imaging demonstrated metastatic disease to lung, liver, spine, ribs, and brain. She received symptomatic treatment at that time and subsequently underwent a total thyroidectomy with central neck mass dissection. Final pathology led to a diagnosis of a stage 4 metastatic medullary thyroid carcinoma, red mutation positive. After the surgical resection, PET-CT scan revealed numerous hypermetabolic lesions involving lymph nodes in the neck and chest, abnormal areas of uptake in the post-surgical thyroidectomy bed, FDG avid lung nodules, liver lesion, and osseous lesion consistent with widespread metastatic disease, as we can see in Figure 3 and 4. MRI was also performed due to headaches and visual disturbances, confirming brain metastasis as well. Nearly 5 years after the initial diagnosis, patient underwent a screening colonoscopy, and 2 polyps were found in the ascending colon. The tumor morphology was similar to the brain metastasis, and the immune profile was consistent with the diagnosis of medullary thyroid carcinoma. We can see the pathology in the Figure 1. As part of the oncologic treatment, patient underwent a total thyroidectomy. She also received pandetanib 300 mg daily, which she was unable to tolerate due to QT prolongation that required multiple dose reduction until reaching 100 mg daily. Unfortunately, the disease progressed. She also tried cabozantinib and prazeltinib, which led to disease progression as well. She underwent gamma knife radiosurgery to the metastatic brain lesion and underwent radiation to the whole brain and to the back. As fourth-line therapy, she has been receiving selpercatinib, another RET kinase inhibitor, which she has been tolerated well. To the present, she has a stable disease. Medullary thyroid cancer is a neuroendocrine tumor of the parafollicular or C cells of the thyroid gland. Most MTCs are sporadic, however, 25% are familiar as part of the multiple endocrine neoplasia type 2 syndrome. MTC accounts for approximately 1 to 2% of thyroid cancer in the United States. We have 2 different clinical presentations, the sporadic and the inherited. The sporadic usually present with a solitary nodule already with metastatic disease in most patients at the time of diagnosis. Cervical node involvement in 70% of patients, breast with upper anodigestive tract compression, or invasions such as dysphagia and hoarseness. High calcitonin and CEA is seen. The inherited form is associated with MEN2A that also present with pheochromocytoma and primary parathyroid hyperplasia. MEN2B doesn't include hyperparathyroidism. As part of the treatment, surgery is the initial approach, with total thyroidectomy preferred over lobectomy. Thyroxine in the form of levothyroxine therapy should be started immediately after surgery. Metastatic tumor with at least 1 to 2 centimeters in diameter that are growing by at least 20% per year, or patient with symptomatic metastatic disease unable to enroll in randomized controlled trials has the PO-TKIs as preferred option over cytotoxic chemotherapy. Serum calcitonin and CEA should be monitored 2 to 3 months after surgery to monitor for residual disease.